Okay, so okay if we start now? It's coming up to 3 minutes past 10. Is that okay with everyone? And then Georgina, if people do join, can you just let us know and then accept them? Thank you very much. Thank you everyone that's joined in today. Thank you to all the clinical experts on the call. We're very, very grateful that you're attending. Me and Mick will be just doing the introductions, if that's okay. So I'm setting some ground rules. If we can all make sure our mics are muted, and can we all ensure that anyone who's got difference of opinion, please obviously respect everyone else's views. We are taking questions, so if you can do the questions in the chat box instead of doing it over the actual Zoom meeting, that'd be much appreciated. Me and Emma Francis on this meeting will be taking down the questions, and then obviously we'll just play it by ear. Please bear with me because Zoom meetings I'm not very familiar with. I normally use Teams, so luckily we've got Georgina and Dr. Varney that's hosting the actual Zoom meeting. So let's get started. Any questions before we move on? No? Okay, so I'm going to pass it over to you guys. If you've got any questions for Dr. Varney, we've also got on the call Dr. Aslam.
Aslam's here as well, yeah.
Yeah.
Great. So I thought I'd start by just giving a short presentation, which will take you through kind of a little bit about COVID, the testing, and also the vaccination, because I think that often helps you kind of give some of the common questions we get answered. So I'll just try and get to share the screen. Here we go. So hopefully you should be able to see the slides now. And so basically, first of all, I thought it was useful just to set out exactly what we mean when we talk about coronavirus, because lots of different language used, lots of things changing. So coronavirus 19 first discovered back in December 2019. Most common symptoms: high temperature, dry cough, loss of taste or smell, all very familiar to us now, I think. And people often have at least one of these symptoms, but they do have other symptoms as well. Of those who develop symptoms, about 80% recover without having to go to hospital, about 15% require oxygen and have to be in hospital, and about 5% become critically ill and need intensive care. And the virus is spread through the droplets that come out of our mouth or our nose, and they get into our body through our eyes, our mouth, or our nose, either when those droplets land straight on our face, or if we touch something and touch our face. Virus can't burrow through your skin, can't climb up your arm. It's when you touch something and then you touch your face, that's how it gets close enough to those wet bits on our face that it can get in. So we prevent the virus spreading.
Yep. Varney, it's not, you're not sharing.
Oh no. let me try again. No, thank you, Manir. Let me try again. Here we go.
There we go, it's on.
Can you see that now?
There we go.
Brilliant. Lovely, thank you. That's the joy of working on split screen, which is why you will also see me looking up to the side, because I have two screens that I work from. So as I said, the virus gets in through the wet bits on our eyes, our nose, and our mouth, and that's why touching your hand, touching something and touching your face gets the virus close. Keeping the physical distance stops those droplets coming out of someone else's mouth and landing on us, and wearing a face covering keeps our own droplets close to our face and stops them spreading. And the more we ventilate rooms, the more we get fresh air, the more that disrupts those droplets and stops the spread as well. We have two main ways of testing for coronavirus. Both involve a swab to the back of your nose and the back of your throat. In one version, they're sent off to the lab. That's the PCR test. And that's really good at finding when there's a very, very small amount of virus. But it doesn't really tell you how infectious you are. It just tells you you've got the virus. Because it goes off to the lab and it needs a fancy machine, it takes several days to come back. So we use that really with people who've got symptoms or who've had a positive rapid test, where we want to be definitely sure that it is coronavirus. And you can book that test through the NHS website or ring in 119. The other version, swab to the back of your nose, back of your throat, and instead of sending it off to the lab, you get to do it there and then. You can now do these tests at home, and you can order the test kits through the government website. It gives you a result in 30 minutes. It's very good at finding out people that are infectious and might not have symptoms, because we know about a third of people who are infectious don't have symptoms, yet they're still spreading the virus freely. And what we're encouraging people to do now is everyone to do these tests twice a week. They're free. You can pick them up from the testing sites across the city, as well as get them delivered to your home. And when you get your test results, you put it up on the website through the link that's in the kit, or you can ring 119 and tell them the result over the phone as well. If you have a positive result, you have to isolate from the point of that positive result, as does your family. And all the legal stuff around requiring you to isolate kicks in from the moment that test turns positive. But we do ask you to do a PCR test as well to confirm it, but also because we're watching new variants, and those are variations of the virus that are appearing all around the world. And we can only do that on the specimens that go to the lab. So that's why we ask you to do that second test if you are positive, because it helps us to check whether it's a new variant or normal COVID, so to speak. So just moving on to vaccines. Vaccines have been around for centuries. The Chinese first used them back in around 200 BC. Most of us will remember Dr. Jenner and the cowpox vaccine that we were taught about in biology at school. And our bodies have loads of different defense systems. Our most important defense system is actually our skin. That stops a whole load of infections. Then we have a kind of general immune defense system. Think of them like our kind of general army. They attack anything that looks foreign in our bodies. And then we have a specialist immune system. There are antibodies, and they're the ones that are like our SAS troops. They're focused at attacking specific threats. And they learn, once they've seen something, they learn it's there and they learn to attack it. And that's why antibodies are a learnt response rather than our general immune system, which attacks anything. So vaccines work by exposing our bodies to a bit of the organism that the disease we're trying to prevent, and teaching our immune system, those antibodies, to recognize it and to attack it. Usually the antibodies focus on the outside of the organism. So they're looking at the outer coat, and there's things called protein spikes. Think of them a bit like buttons on a coat. So our body sees a virus entering our body, and it's got buttons on it that it recognizes, and it deploys the immune response, the antibodies, to attack anything that has those buttons on it. And there are lots of different ways that vaccines are developed. Some of them use a dead version of the virus. Some use bits of it, so they take the buttons off the virus and they sew them onto a different virus. Some of it use the instructions, the recipe card for how to make those buttons, and they introduce that into our cells, into the factory bit of our cells, so that our cells start to produce just the buttons, and our body sees the buttons, goes, that's foreign, learns how to attack it. So there are slightly different ways they work, but in effect, they're all exposing our body to the buttons on the virus, those protein spikes, so we learn how to recognize them and learn how to attack them. Vaccines all follow a pretty similar development process. So we start in the lab, then we move on to animal trials, then we move on to human trials. And there are 3 stages of human trials, looking at, is it safe in humans? Does it create the response we expect in humans? And when we do much larger trials, does it create the response in lots of different types of people? And throughout all of this, there's a safety monitoring process where any side effects are reported to an external agency who monitor it. And if we do see something unusual happening, then the trials are often paused while that's investigated. And you'll remember actually back in the early autumn last year, one of the big trials was paused because of a concern. It was investigated and it was found that it wasn't being caused by the vaccine itself. So at the end of all of those trials, all of the results from the research are given to the regulator. They look at them independently and they go, yes, it's safe, it does what it says on its tin, and we recommend therefore it can be used. And then manufacturing starts. And as the vaccines rolled out, we continue to do the safety monitoring through a thing called the yellow card system, where any adverse reactions are reported up through a national system. Because as we roll out the vaccine to more people, we will start to see some very, very rare side effects. But we only see that when we're giving the vaccine to millions of people, because in a trial, we'll be giving it to tens of thousands of people, and there won't be enough people for that kind of occurrence to happen. Now, with the COVID vaccines, they all followed exactly the same steps. They didn't jump any steps. But normally when we do this kind of rollout, at each stage, you have to go and get permission from a committee. Those committees only meet every couple of months. You have to get funding, and you have to put in funding proposals, and you have to recruit people to do the trial in the context of where the disease is. So you're recruiting people both to have the vaccine, but you also want to recruit them in areas where that disease is common, so you can see if the vaccine is defending against the disease in the way you think it should. Now, obviously, with COVID, a couple of things happened. First of all, basically, everyone said there's money for research. So researchers didn't have to put in lots of applications. They got given the money pretty quickly. The committees that needed to meet were called when they were needed. So rather than being told, I'm sorry, you've just missed a meeting, the next one's not for 3 months, they were told, actually, no, we'll call them next week. So that moved everything faster. And the third thing was when they needed to do the trials, COVID was around a lot, and there were a lot of people that wanted to volunteer for the trials. So there wasn't the problem getting the recruitment that they needed. And those trials were held in multiple different countries, which also relatively unique that we've been able to test this vaccine in different ethnic communities because they were done in different parts of the world at the same time. Which is really positive as well. So it's a bit like thinking if you drive from Longbridge to Sutton Mere Green on a normal day before COVID, it will probably take you a good hour and a half with roadworks and traffic lights and everything else. And now imagine what it would look like if you were driving with every traffic light turned green, there were no roadworks and no traffic jams. And that's the difference. That's why the COVID vaccine was so much faster. So at the moment, we have three main types of vaccine that have been approved. 2 of them work in very similar ways, and the other one's slightly different. So the 2, Pfizer and Moderna, work in the same way in that they introduce the recipe card for making these protein spikes, the buttons, and they do that by wrapping it in a kind of fat and protein envelope. So the way it's introduced into the body is slightly different, and that envelope is the engineered bit. And once that gets into the body, the recipe card goes into the muscle cells in our arms, and the little factory bits of our cells start to produce the protein spikes. Body recognizes them, develops an antibody. The AstraZeneca is slightly different because instead of putting in an artificial envelope, the recipe card is put into what's actually a virus that causes colds in monkeys, but doesn't do anything to humans. And it's just a slightly different way of introducing the same recipe card into the body. All 3 types of vaccine take 2 doses. We know after the first dose, your risk of dying or ending up in hospital reduces massively, but you need the second dose to really lock it in, but also to give you the protection from infection, which comes much more strongly after the second dose. And it takes about 2 to 3 weeks after each dose for you to get the benefits. And that's because the body is learning how to build these antibodies. All 3 vaccines are very effective. Over 80% effective against the coronavirus, and against most of the new variants, they are still over 70% effective. And to put that in context, the flu jab is only about 40 to 50% effective. So these are much more effective than the seasonal flu jab, which is much better than everyone expected. None of the vaccines contain any animal products, and neither do they contain any fetal products, so any baby related products. There are side effects. With any medicine, there are side effects. Most of these are mild and short-lived. Most people the day after the vaccine feel a little bit groggy. With Pfizer, often people complain about a sore arm. With AstraZeneca, a bit headachy and have a bit of a temperature for a day or 2. But just taking paracetamol helps control that. And that's because your body is reacting to these protein spikes and to having had the vaccine. In general, the vaccines are safe for people who have common allergies, but if you've had a serious anaphylactic reaction to any medicine, or particularly a vaccine before, you should tell them when you go for the jab, because the Pfizer one we tend not to give to people who've had serious anaphylactic reactions to medicines before, because there's a specific chemical in it that is present in some other medicines, whereas that isn't present in the AstraZeneca one. So in general, the AstraZeneca one's pretty much safe for everyone. The Pfizer one, we hold back on people who've had that anaphylactic reaction before. The rollout, as you know, is going through age groups, and now carers are entitled to get the vaccine and should be taking up the vaccine to help protect the people that they care for as well as themselves. And we've been working through those groups now, and we're now in the process of rolling out the second dose to those 9 priority groups as we go. I'll just talk briefly about variants and also about vaccine risk for a moment. So variants, you'll hear on the news that these are viruses that mutate. It's perfectly normal. We know viruses, because the way viruses reproduce, in that they can't reproduce on their own, they have to invade our cells, use the factory parts of our cells to make new baby viruses. And because they're using someone else's kit, each time the babies are slightly different. And those are the variants. And most of the time that makes no difference at all. But every now and again, we see a new variant that is more infectious, more deadly, or makes the vaccine less effective, or a combination of all of those. And the most common variants that we're watching at the moment, what are called variants of concern, are from South Africa. We have the Kent variant in the UK, which was much more infectious than the old version. And the variants from Brazil, which are quite concerning because they are more infectious, and it suggests maybe more deadly and more resistant to the vaccine. And there are some variants in Japan, and now also we're starting to see some emerging from the US as well. Each time we see variants, there are trials to look at, does the vaccine still work? And at the moment, both Pfizer and AstraZeneca and Moderna all look to be strong against the Kent variant and against the South African variant. The Brazil variant, I think we're a bit more concerned about. And there's a lot of effort to try and contain that within Brazil at the moment, because it is quite a significant change. If we do see more variants appearing, what's most likely to happen is that we would see a booster coming in the autumn, which would top up our immunity against these variants. So it wouldn't be starting from scratch, but it might be a single jab booster in the autumn to cover us against some of those variants. I wanted to just include one slide on clot risks for you to talk about it, because it's obviously been in the news recently, that as we've rolled out millions of doses of the vaccine, of the AstraZeneca vaccine, we're seeing a very, very rare but serious side effect, which is a particular form of blood clots that have been occurring. But to put this in perspective, there's about 4 cases of these for every 1 million people given the vaccine. When we look at the number of people who have serious blood clots if they catch COVID, about 165,000 people in every 1 million will get a serious blood clot if they catch COVID. So the vaccine is much, 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 much lower risk than catching COVID itself. Now, one of the reasons that the regulator's been looking at this, and the guidance is slightly changing for the under 30s, is, as you can see in the diagram at the top, that the risk of ending up in hospital in ITU from COVID gets much lower as you get much younger. And this diagram is only looking at the risk of ending up in intensive care, not at the risk of blood clots or anything else. And what it says is up until 30, your risk of ending up in intensive care if you catch COVID is much, much higher than your risk of getting a blood clot from the vaccine. But under 30, it gets closer. And that's because under 30 is very unusual for them to end up in intensive care. So that's why the decision's been made that under 30s will be offered a different vaccine, the Pfizer one, and probably the Moderna vaccine, which is just about to come out, because we haven't seen this additional clotting risk with those vaccines. And that will start to come through over the next couple of weeks as those vaccines become more available. But above 30, your risk of having a clot due to the vaccine is still about a quarter of the risk of you ending up in intensive care with COVID. So there are, one of the things is this is a very, very rare side effect, but and there's still not clear evidence actually that it's being caused by the vaccine. And this is one of the challenges when you have something that's so incredibly rare. What you've got to do is look at the individual that got the clot, try and work out when they had the vaccine, was there any evidence that they might have caught coronavirus, which could cause the clot in its own right, just before they had the vaccine or in the 2 to 3 weeks after the vaccine. So that's that's why it's still not 100% that this is driven by the vaccine, but we're erring on the side of caution, particularly for those under the age of 30. And the advice is also getting stronger that if you have side effects that are lasting more than a week, then you should be reaching out to your GP for advice, because it would be very unusual for those side effects, particularly in these situations. People had quite severe headaches that were going on for 10 to 14 days after the vaccine. That is very unusual. So if you are having serious side effects after 7 days, then please reach out and talk to a healthcare professional. But as you can see, the risk from the vaccine is incredibly low. And as I said, we're still not 100% sure that it's being driven by the vaccine itself. There's a lot of information there, but there's also more information online. If you'd like it, we've also translated these slides on the council website into, I think it's about 10 different languages as well, so that you're able to go through them at your leisure. So I hope that's been helpful, just giving a bit of an overview before we take any questions.
That was brilliant, Justin. Thank you very much. Really helpful. I think we have had some questions in the box. I'm having a look. Okay, so this is from around a young carer. So the question is, I have a question on behalf of a young carer. My mum has bipolar and I'm worried about the long-term effects of the vaccine. Is there anything you can tell me?
Dr. Aslam, do you want to pick up that one?
Yeah, I can. Do you mind if I just make a quick comment? I will answer this question. It's just a quick comment about some of the presentation that Justin has given and work that we've done on carers for the last 5 years in West Birmingham. So we know that 2% of the population are carers. About 70% of carers come into contact with the NHS, but we only record around 10% of those. So we know that we've had work to do. So what we've done in practices across West Birmingham is we've set up a carers lead in each practice. We asked them to keep a carers register at each practice as well. And being a carer means you have enhanced access to some of the services that general practice offers. And we hold 2 of those as markers. So one of them is that carers receive an annual flu vaccination, and that will be alongside the COVID vaccination as well. So priority access to those vaccinations. And then the second thing is around an annual health check as well. And I think it's worth reflecting. I think it's really important because I think we started this conversation by saying, there is new information about the AstraZeneca vaccine. We just need to be really careful. Dr. Varney makes a really good point. One in perhaps 100,000, perhaps even more than that, will get this very rare clot that forms. 1 in 10 people will get some symptoms of long COVID, having had COVID, and that is a serious problem for people. And long COVID is a multi-system disease, so it is associated with extra incidence of clots. It's associated with fatigue, brain fog, shortness of breath, chest pain, and these symptoms last for many, many months. And we're learning more and more as we go on about this. So the risk of having COVID and the complications of COVID are significantly worse than associated with the vaccine, and the vaccine will protect you from having these symptoms. So I think it's just worth being mindful about that. Now, we have lots of experience with lots of different types of vaccines, children's vaccines, adult vaccines. We have vaccines in the elderly cohort for shingles. We have quite a significant amount of experience with vaccines. We know that the short-term side effects, we're hearing more about them as we go on. We haven't had a very high side effect profile with the vaccines with Pfizer or the AstraZeneca vaccine. We know that most people will get symptoms for around about a day, maybe a couple of days, and then feel significantly better as well. And at 2 weeks, they will be relatively protected from hospitalization. So what we will always, and it's the right thing to do, is to keep an eye on what these side effects are, these rare side effects, making sure that we are aware of them, people are aware of them, and we investigate them appropriately. Long-term side effects, we give the flu vaccination every year, and we don't have any long-term side effects from that. What we do is we protect people from getting flu, and the benefit of having a vaccination will reduce significantly the hospitalization of people, and we expect that we have seen that, and we expect that to be the case for COVID as well. So in terms of long-term effects, we will keep a check, but at the moment we're not expecting any. We don't get a lot of long-term side effects with any of the vaccination programs that we have.
Okay. To just go back to the original question, Doctor. So I think this young carer was concerned about maybe the vaccine having an impact on their parents' medication.
Oh, okay. So it does not have an impact on medications.
Okay.
So getting COVID and having complications of COVID will affect most chronic diseases, particularly your metabolic chronic diseases, things like diabetes and COPD, but the vaccination does not cause problems with that. And she will, her mother will fall into the categories of either age-related call-up or clinically extremely vulnerable. She will be prioritised. Mental health patients are prioritised anyway in practices within West Birmingham, so they should have enhanced access to care. General practice, I might add, is open. Access is by telephone and then face-to-face as required. So please, you can expect to access general practice in the way that you have done throughout this period.
Okay, brilliant. A few more questions have come through. So as the shops are reopening today, what advice do you guys have as a clinical team for carers that's only had one vaccination but are keen to go to non-essential shops? Would you advise against it or not?
I think I'd probably say be cautious. I think couple of things. One, we should be really encouraging everyone to be testing twice a week, irrespective of whether you've had the vaccine or not. You should still be doing the lateral flow twice a week. That helps reduce your risk of spreading the virus, but we want everyone to do it because that will make going to the shops a lot safer for all of us. If you are going to the shops, please keep physical distance, wear your face coverings, be cautious about it. Your first dose, after about 2 to 3 weeks, will have kicked in and be reducing your risk of hospitalization and death. But it still, you need the second dose to really get the full effect of reducing the risk of transmission. And the reason we're vaccinating carers is both to protect you, but also to protect the people you care for. And I'm sure many of you have been incredibly cautious about going to the shops to protect the people you're caring for over the last few months. And I would say stick with it because those spaces, particularly the indoor spaces, remain the highest risk of transmission. And we have seen in other countries very, very rapid acceleration back into a third wave. So I would say still be cautious and sensible. But it's great you've had the first dose. It's certainly going to help keep you out of hospital. But I think stay cautious and keep testing.
Okay, they're coming through thick and fast now, guys. Another question from a carer, just bear with me a second, they're going up too quick, is do the risk / side effects of the second vaccine increase with the second dose?
So I'll pick this up, Dr. Varney, if that's okay. So the risk of clot in the first vaccine is incredibly rare. So we need to understand that a little bit more. What we do know, or what we have got evidence of is that once you have the first vaccine, you don't have problems with that. And when I mean side effects, I don't mean the effects of the vaccine. If you have a vaccine, you are likely to be unwell for 24, 48 hours. You might have a temperature, a slight sore throat, and feel fatigued. That is an effect of the vaccine. That's your immune system kicking in and fighting off whatever the virus particles it's coming across. So that is not a side effect, but it is an effect of the vaccine, and it is showing that the vaccine is effective. The evidence that we've got with the second vaccine is that people are tolerating it much better. They're having less of the symptoms that they had on the first vaccine, and they're incredibly unlikely to have a clot or any evidence of side effects after the second vaccine. So that's the experience that we're having. We are at a stage where we've vaccinated 80% of carers now with the first vaccine, and we are running through a program now with the second vaccine. So we're learning more as we go along. We're being cautious. We're trying to get people to explain to us if they are having symptoms or side effects. But at the moment, with the second vaccine is much better tolerated than the first. But the first one's pretty well tolerated.
Thank you very much. I think Justin might have answered this question, but I'm just going to go through them anyway. We're exploring carer support groups being face-to-face again, and ways we can do this. What is your view on this with carers still having their vaccines? So obviously take a common sense approach.
Yeah, so I mean, support groups are allowed to meet provided they've got risk assessments in place. Whether you're vaccinated or not doesn't change whether you wear a face covering, and it doesn't change social distancing at the moment. Certainly my advice is anyone who is hosting any form of bringing people together indoors should be asking those people to do a COVID test in the 2 to 3 days before they come for the group session. So I'd focus less on the vaccine, to be honest, and much more on our carers testing regularly and helping them to get their tests regularly, because actually that's a really good way of stopping infection getting into those group settings. And certainly, you know, it's one of the things as a council we're looking at the moment about how can we really encourage people to test regularly before they come to things like gyms or libraries, because it really reduces the risk for everyone.
Okay. Thank you very much. Another question from a carer. Can you explain why the BAME population seem to have been more seriously affected by COVID? I worry that we will see BAME people start to be affected by the vaccine.
So if I'll kick off on this one, and Manir might come in as well from a clinical point of view. So what we've seen in terms of the pandemic so far is that people from ethnic communities have been more affected, and that is a reflection of people from ethnic communities being more likely to work in occupations that couldn't be done from home. When we were locked down during the first wave, there were far more ethnic people who were working in health and social care, security guards, restaurants, working in the supermarket, warehouses, all of those jobs that people couldn't sit from their spare room like I'm doing and do their jobs. So their exposure was higher, and we saw that in the case rates. Then we also saw a higher proportion of people in ethnic communities ending up in intensive care, ending up dying with COVID. And what we saw there was really that reflected the fact that the health of people in our ethnic communities in general is worse than the health in our white British communities, particularly for conditions like diabetes and high blood pressure, that we know that if you catch COVID and you've got those conditions, you're going to have a rougher ride. And if those conditions aren't well managed, then it's going to be even worse. So in effect, they were coming into this pandemic with a much worse starting point than many of the white British population. So that's why the first wave, and to some extent the second wave, has been so much worse. There are other factors. Some ethnic communities live in much larger households, and we've seen spread in the house has been a really important reason why we've seen rapid numbers grow in some communities, and that has played a part as well. But I think it's much more a combination of people still having to go to work and also their baseline health being much worse. In terms of the vaccination, I mean, it does make me worried that when I look at the vaccination uptake in some ethnic communities, it remains low, because when we see a third wave coming, it's the people that haven't got the vaccine that are going to be most vulnerable. And yet some of the communities which have been worst hit have been taking up the vaccine least. So then they'll be hit worst again when there's a third wave. So I think that is a real concern. We do know that all the vaccines have been trialled across the world in different ethnic communities, particularly AstraZeneca, actually, which had a large trial in South Africa that had a lot of Black and Asian people in the trial. So we know that the vaccines work in all ethnic groups, and there are no different side effects in different ethnic groups either. So that's really important as well. But I think it is a concern that if we can't get those vaccination levels up for everyone, then there are a group of people who are going to be really vulnerable when the third wave comes.
Again, I think you've just answered the next question as well. So thank you for the presentation. Do you have any updated information regarding vaccination uptake with the Black, African, Caribbean communities in Birmingham?
So we publish this on a weekly basis. It'll be coming out, usually goes up tomorrow evening, on the Council's Local Outbreak Engagement Board page on CMIS. And I know Councillor Brown's on the call, and I suggest he'll send that link round to everyone. But you can have a look at there. Weekly, we update it, and we break down the data by different ethnic group, also by deprivation and by gender, and we break it down by ward. So there's quite detailed information, and we show how things have been improving over the last now 6 weeks we've been doing this. And we were the first authority and NHS system in the country to put this into the public domain. So you can track that there. In general, it's going up. Our poorest uptake, when I last looked at the data, and I haven't looked at it yet today, is in our African community, particularly in our over 80 African community, but they are also quite a small community. So the other thing we've got to keep in mind is that in some of our communities, in some of the priority groups, we're talking about 300 or 400 people that are eligible for the vaccine. In some of our other ethnic communities, like our Pakistani community, about 3,500 Pakistani people over 80. So when we look at actually the number of unvaccinated people, it's not quite the same as looking at the percentages. But do have a look there, because you can track it every week.
That's great. Thank you very much. Kara's asked if you can pick up a kit from your local chemist. Is this correct? Yes.
So you can now get home testing kits from the majority of chemists. You can get them from the testing sites, the fixed testing sites that we have across the city. If you look on the council website, there's information, or you look on the government website, if you just put COVID rapid test into Google, there's actually a postcode search engine. So you put in your postcode and it'll tell you where your closest sites to pick up a home testing kit are. And they give them to you in a box of 7, which should last you about a month. And you can also pick them up for your whole household. So if you go along and say, they'll say, how many people are in your house? And you say 4 people, they'll give you 4 boxes. And they're only, they're barely the size of an A4 sheet. They're not even that big. So it's pretty easy just to pop in your bag when you're out doing your shopping.
Thank you very much. Next question is from a young carer. What do you know about the third wave, and is it inevitable?
I think we will see a third wave. I think we're seeing in Europe a third wave at the moment, but the European situation is slightly different. So the European third wave is being driven predominantly by the Kent UK variant and the South African variant, in countries that didn't really have that before, and particularly France and Italy. That's been what's driving it, as well as actually their compliance with lockdowns being not as good as ours. So that's what's been driving it. I think here we are further along with vaccination. We've had the Kent variant accounts for over 90% of new cases currently. And we know that the Kent variant kind of wins when it's battling with the South African variant. So that's buffering us. Where I think we will see a third wave is probably in the autumn, where if more of things like the Brazilian variant start to appear that the vaccine's not as effective against, and any natural immunity that's still around isn't effective against, then we will see a third wave. So my hunch is, if we stick to the rules, we'll get a pretty relaxed summer. And then coming into the autumn, we probably will have to see face coverings in indoors. We might well have a booster jab. And we need to stick with the hand washing, whatever, because it's pretty good for stopping diarrhea and vomiting bugs as well as COVID. So I think third wave more likely here in the autumn, but I think it probably is inevitable based on most of the world still hasn't got vaccine. And until the majority of the world is vaccinated, we will still see variants appearing. And each variant is a threat to all of us, not just the country that it's in.
Lovely, thank you very much. Can Muslim carers receive the vaccine during Ramadan? And are there any health implications receiving the vaccine while fasting?
So I was Friday prayers on last Friday, and the Central Mosque and most of the Muslim scholars think that having a vaccination while you're fasting doesn't break your fast. So having a vaccination is okay to have when you're fasting. I appreciate that there will probably be some variation on that thought, but the majority of Muslim scholars think that. Having the vaccination, like I said before, is going to give you probably around 24 hours worth of symptoms where you might have temperature, feel generally unwell, but it generally doesn't last much longer than that. So you have a difficult 24 hours, but you will be vaccinated. And this is a time when people will, especially in the Muslim community, will get together and want to be in each other's houses. We would discourage that, but the safest thing that you can do is to be vaccinated and then give yourself the 2 weeks, ideally to have the second vaccination after the 3 months. And the 2 week period after that as well for complete protection. I noticed there is a similar question in there about, Muslim carers, I had the vaccine, I was told it wouldn't stop me spreading COVID. I think it probably does reduce. We're learning as we go along, but it probably does reduce it because you're not having symptoms. And symptomatic COVID patients are the people that spread it to other people. I mean, I appreciate there is asymptomatic spread as well. So I think it probably does reduces your risk of getting infection, becoming unwell, passing the infection on. So I think vaccinating against COVID is the best thing that you can do. Do it now because it gives us opportunity for the immunity to kick in, which will take a couple of weeks after the vaccination.
Thank you very much. I think we've got one more. I'm a carer and would really like a respite break and have a chance to go to Spain late in the summer. But I worry about bringing something back to my mum, the cared for. Again, I think you've really got to get there.
Yeah, so travel. So first of all, if you're booking travel this year, please check your insurance, check the rules about moving it. Most of the reputable travel agents will have a clause that says if there's a change in restrictions, you can move it without any cost. But please do check that because I know people did get caught out last year. The other thing you need to check is what the quarantine requirements are. Now, they will change as the virus changes around the world. And we know there are people that were in Pakistan, for example, last week, were expecting to come back and be able to quarantine at home. And actually Pakistan went on the red list. So now when they come back, they have to go into a quarantine hotel and they have to pay for that. And that's about £1,000 or more for the week's accommodation. So you have to keep that a little bit in mind in terms of judging, do I go, don't I go? Because that is always a risk that the country might change onto a red list and then you're going to have to pay for the quarantine hotel and not be able to quarantine at home. Irrespective of whether it's a red or non-red country, you will need to test. And again, there's a cost related to that. And you test twice during your quarantine period. You can pay for a third test, which allows you to come out a little bit earlier if it's negative. So what I would say is check on the website. There's a lot of information on the .gov website about travel and planning for it. And the reason that we have the quarantine in place is to make sure that you don't bring the virus back. Now, if you live with the person you care for, one option you could think about is whether when you come back, you quarantine with a friend, with someone different, if you're able to, because that would stop you potentially putting that person you care for at any higher risk until you've had the quarantine tests and you know you've definitely not brought COVID back with you. So that might be something to think about if you live with the person you care for, to try and stay with a friend while you're doing your 10 days of quarantine, just to be on the extra safe side.
Brilliant. No other questions, I don't think. Anybody else? Anything else?
There is a question on there about the BAME community again, isn't it? So, so is there been an increase? So, if I just let you know that a couple of weeks ago we did we had a conversation very similar to this on Zoom with members of the Bangladeshi community, and what they told us was a doctor calling some of our Bangladeshi patients or elderly patients who were wanting the vaccine wasn't convincing them. What they wanted to have was a conversation with somebody who spoke their own language from their own community, and they wanted to have vaccination in a place of their choosing, close to where they lived. And so we did that. We did that at the Bangladeshi Centre in Aston. They organised themselves to have 400 people that were on our priority list come and get vaccinated. So they created a list for themselves and they organised themselves to have 400 people on that list. And although that's 400 people that are unlikely to get serious effects from COVID, unlikely to get hospitalized, unlikely to pass on their infection to other people that they live with. So I think the BAME numbers are improving. They're not where we want them to be. I think Dr. Varney makes a really good point that in a third wave, those people that are not vaccinated will be the people that are most vulnerable, and that's a real challenge for us, because we've created a problem where we've said, or we've got a community that's saying we don't trust the vaccine, but then when we have a third wave, that's the community that will become or likely to become the most affected. So we just need to be very, very mindful about that. But just to reiterate, to book a vaccine in a mass vaccination site or a pharmacy, call 119. We still have vaccination sites within general practice, which has done 70% of the total vaccinations in the country, actually. So, and you can do that by calling your GP or waiting for them to get in touch with you. So there is opportunity to book your vaccine if you haven't had it. 119 is the route that I would go down to book it through the pharmacies. We want pharmacies, particularly with the new cohorts, to take on the vaccination program because we need general practice to get back to doing the general practice things, you know, managing our chronic diseases and managing patients. So.
Just on one of your point there, Dr. Aslam, so how could we potentially work together to make sure that we are identifying those hidden carers or those carers that do not want the vaccination? Because obviously you're coming in from a clinical point, and then us Birmingham and forward carers are coming in from a very frontline point. So how can we potentially bridge that gap?
Well, I think there's a great opportunity here, isn't there? Because actually we have had a lot more people stating that they're carers coming in and telling us, and whether they were coded as carers or not, it creates an opportunity for us to create a list of people that are caring. We know that we underestimate significantly the amount of people that are carers, and those people we need to support better through the health system, but also through the social care system. So, so there is an opportunity here to make sure people come forward, prioritise their access to the COVID vaccine, record that they're carers, and make sure that they get the enhanced level of support that we can offer them. And I think we need to think now of COVID, of course, but we need to think going forwards about how do we support these people in a new post-COVID era.
So also, just to add to that, it's really important people register with the Carers Hub. So we put in some additional resource to support the Carers Hub in Birmingham to help with this, and there are two ways that the system kind of categorizes carers. So there's people that receive carers allowance, so the DWP kind of group of carers, and then there's also a group that don't receive carers allowance that are what are called local authority carers. So we're looking at vaccination uptake for those two, but that's why we put some additional resource into the Carers Hub to help us capture people who aren't necessarily getting carers allowance, but are providing care and care support so that they get access to the vaccine as well. And I certainly know some of my friends in Birmingham who are those family carers registered through the hub and have had their vaccine now because they did that registration. So really important to just give a shout out to the Carers Hub that really helped with this.
Thank you very much. We've got some few questions coming in. I know we've got 9 minutes left, so we'll go through them quickly. So question from a carer: can you choose which vaccine you have?
Nope. We don't have enough vaccine to be able to kind of pick and choose. The vast majority of people will be offered the AstraZeneca vaccine. That's the one that doesn't need the special fridges. What we are going to start seeing is for the people under the age of 30, because of this very, very rare potential risk, they will be offered the Moderna or the Pfizer vaccine, but that will be probably through a slight alteration to the booking system, and that's being worked through nationally. I would expect it to come through this week.
Brilliant, thank you very much. Do you know what percentage of carers in Birmingham have had the vaccine?
So I've got some numbers for that here. So I think Justin described the two different carers, or the list of carers. So local authority carers, we've had 80% have had the vaccination within the Black Country in West Birmingham, and the carers of GWP is at 71% have had their first vaccination. So those numbers are good. We could do with them being significantly better. We are at in our over 80 groups, we're at 92%. In our over 75s at 93%. Over 70s at 92%, and over 65s at 90%. So we need to get them up at 95%, and that would be, which I have to say is a remarkable achievement, actually, to have a non-nationally mandated vaccination program that gets us to this stage is nothing short of amazing, actually. And I wouldn't have predicted that we could have got this far earlier on in the year. So well done, everyone that's been involved in that.
Just a few more questions, guys. How long after testing positive for COVID should I wait before being vaccinated?
28 days. So it's pretty clear. So once you've had a COVID test, wait 28 days, get vaccinated. You'll get vaccinated. You still do need to have the 2 vaccinations. They are working on looking at the evidence in terms of antibody response. So maybe we'll have different level of information as we go forwards. But at the moment, it's 28 days.
Thank you very much. What advice would you give a carer who's had the vaccination and cares for someone that does not want the vaccination?
Try to convince them. It's the right thing to do. It's the safest thing to do. I had a patient of mine, I mean, it wasn't a vaccination issue, but I thought would benefit from going to hospital for a couple of days to take care of a condition. Actually, absolutely refused. And actually, people have a choice. You know, we haven't nationally mandated this. It's not the law to have the vaccine, so people have a choice. I think if there's information that we can give them that that would help them make a better decision, or in our minds, a better decision, let's help them. Let's navigate them through the information that's available. But ultimately, people have a choice. The best thing that carer can do is to have their first and second vaccination and not bring COVID into their homes. That would be a great thing for them and a very beneficial thing for them to do. Yeah, ultimately, if there's something that we can do to help to convince people, then we should do that.
Any advice for my particular service, where we've got carers specifically caring for people with mental health, sometimes quite extreme mental health as well, who do not want the vaccination? Any pointers you can give us to try and engage those people in regards to getting their vaccination?
I think the personalization is really important here, because people will make choices based on individual factors, so the factors that affect them, and to understand those in greater detail. The personalization of this to get us up to the 90-95% is going to be time intensive, but it's worth the effort and time that we put into that. So rather than give you a general comment that this is what you should do, but actually individually, if there are challenges and we can meet those challenges together, let's take the time out to do that, and we'll make time to do that, because actually I think the long-term benefit would be great.
Brilliant. And I think the last question, I'm chair of Birmingham Parent Carer Forum. We are working towards this, and then there's a www.birminghampcf.org. That's the question.
I don't know what the question is. Is that it looks like a statement?
That's what somebody stated, so I just want to make sure I read it out and I'm not going to miss anything off there. So if Sabia wants to clarify on that, feel free.
I think the work that they're doing is fantastic, isn't it? So if they're registered as carers, great, let's continue to support them. If they're not registered, please at least register with the practices or with the carers, as Justin described. I think that information I think between local authority and health, we need to make that information more available. So, you know, certainly the people that don't have access to that information, let's make it easily available. It's not so easy to put it onto a screen in a GP practice. So let's think differently about the websites and how we push information to people so that they can get the appropriate support that they need.
And utilise care leads as well. So you said you've got care leads in all your practices as well?
In every practice, yes.
Okay, with 3 minutes left, does anybody go? Oh, sorry, yes, we are encouraging our parent carers to register with the surgery or carers hub. Thank you. Okay, some clarification on that last question.
Can I just add in a little bit on, because one of the things we often get asked is why don't we give the vaccine to children? Obviously parent carers may be concerned about why their children aren't being given a vaccine yet. At the moment, we haven't had the trials yet to be confident that the vaccine gives enough of immune response in children. So we did the vaccine trials in adults. There were very, very small numbers of children in the trials. So there were additional trials that were started back in the late autumn to look at how the vaccine worked particularly in teenagers. Because we see COVID behaving in teenagers very similar to the way it does in the adults. And they should report over the next couple of months. However, if a clinician feels that a particular young person's risk from COVID is very high because of their clinical situation, they can use the vaccine off license, but it's done on an individual child by child basis, usually by the paediatricians in the hospital, because it is a very rare thing to do, but we can do it on those circumstances. But we hope those trials on children will come through over the next couple of months, and then we may well see vaccine being offered to children as well. But that's the reason at the moment we don't.
Excellent, thank you very much. Okay, seeing we've got no other questions, I just want to say thank you very much. That was absolutely brilliant, I have to say. So